Hello and welcome. We're going to be talking about the cervical exam and HPV. We're going to have a quick overview, talk about transmission, risk factors, prevention, screening, and results interpretation. So welcome aboard. So there's a bunch of statistics we could talk about, but really, why do we care? Incidence and mortality remain high from cervical cancer, especially in certain populations. Among African American women, the deaths are at 10.1 per 100,000. Even the American Indian and Alaska Native population and the Hispanic population have higher than average rates of morbidity and mortality as well. So this is an all-woman concern, and so we want to take care of our patients to the best of our abilities. So let's go along. So let's talk about HPV. 16, 18, 31, 33, 45, 51, 52, all the numbers that we learned in medical school are still relevant. Transmission, of course, is through sexual intercourse. And actually, the frequency of genital infections is associated with both the number of sexual partners and the age of onset of sexual intercourse. So what are the risk factors? HPV by itself doesn't cause malignant transformation of the infected tissues. There's a bunch of cofactors like immune suppression, tobacco use, ultraviolet radiation, pregnancy, folate deficiency, and they've all been associated particularly with the anogenital mucosal malignant transformation. Patients on immunosuppressive drugs and immunocompromised patients, such as our HIV patients, are especially susceptible to developing HPV infections and having them for longer. Like I said before, sexual activity is a risk factor. And then in regards to tobacco smoking, fun fact, in women who smoke tobacco, there were measurable amounts of potent carcinogens as well as other compounds from cigarette smoke that were identified in the cervical mucus of these women, and those likely play a role in the increased prevalence of HPV malignant transformation compared to patients who do not smoke. Also, past medical history is a risk factor. If you have a history of high-grade squamous cell intraepithelial lesions of the cervix or invasive squamous cell carcinoma of the cervix, you are at increased risk of subsequent invasive cancer in other tissues as well of the anogenital mucosa, specifically the vaginal and anal tissues. So how do we prevent it? As you know, we do have an HPV vaccine, and per the USPSTF CDC vaccination schedule, you can get this vaccine starting at 9 years old all the way up to 45. Ideally, if your patient's between 27 to 45, this is a shared decision-making process with your patient. But the schedule going up to 26 years old, you're either going to get a 2 or 3 dose series, depending on your age at initial vaccine or the conditions in which you received the vaccine. So if you're 9 to 14 at your first shot and you got 1 or 2 doses that were less than 5 months apart, you're going to get another dose. But if you're 9 to 14 at your initial shot and you receive 2 doses and they are at least 5 months apart, you're done. And if you are 15 or older at your initial vaccine, you're going to get a 3-dose series. It's going to be at your first shot at 0 months, and then 1 to 2 months, and then 6 months. 5 months is that key minimal interval that should be between dose 1 and dose 3. And if you administer it too soon, you should repeat the dose. So key thing, between dose 1 and dose 3 should be at least 5 months. So what about screening? So if you're less than 21 years old, just don't do it. They don't need to. It causes harm to the patient, and they are much more likely to resolve the infection and not have developed the cancer. If you're between 21 to 29, the recommendation is the cervical cytology every 3 years. If you're between 30 to 65, the recommendation is going to be either cytology every 3 years or high-risk HPV testing every 5 years, or you can co-test together every 5 years. And if you're over 65, if you've had adequate prior screening, just stop. But if you haven't, or you're a high-risk patient, go for it. Screen them. So you might be wondering, what is adequate screening? Who is high risk? What about a hysterectomy patient? What about a symptomatic patient? What then? So the American Cancer Society, the American Society for Colposcopy and Cervical Pathology, and the American Society for Clinical Pathology, aka Alphabet Soup, came up with what adequate prior screening is, and that is 3 consecutive negative cytology results or 2 consecutive negative co-testing results within 10 years before you stop screening, and the most recent test has to be within the past 5 years. They also said that routine screening should continue for at least 20 years after spontaneous regression or the appropriate management of a precancerous lesion, even if it goes over that 65-year-old mark. You still want to screen them regularly. And once screening has stopped in women over 65 in general, it's not restarted even if they have a new sexual partner. So who's average risk and who's high risk? A patient is considered average risk if they have all of the following. They are asymptomatic, they are immune competent, and they've had all normal cervical screenings in the past. Patients are high risk if they have a history of HIV or immune suppression, or if they've had in utero exposure of DES, which I know is rare now, but still happens. So like I said, HIV patients, they're way more likely to have persistent HPV, and they have higher rates of high-grade dysplasia. Our immune-suppressed patients, we're thinking about the ones who are on long-term immunosuppressive therapy. Those are our solid organ transplant patients, our hematopoietic stem cell transplant patients, our lupus patients, our IBD or RA patients who currently require immunosuppressant treatment. They all have a decreased rate of clearance of HPV, and they have higher rates of cervical dysplasia and cancer. So for our HIV patients, initial screening is going to be started at the time of diagnosis, but no sooner than 21. At 21 to 29 years old, you can use cervical cytology. Over 30, you can either use cervical cytology or co-testing. But the key thing here is that primary HPV testing alone without cytology is not approved as a screening form for HIV patients. Also, you're generally going to get a screening colposcopy done at that initial screen visit. And given the high rate of having multifocal HPV disease and high rates of cancer from HPV, you want to thoroughly visually inspect the anus, the vulva, and the vagina to make sure there's no other HPV cancers involved. Of key note, our IBD and RA patients who are not actively on immunosuppressive therapy are not at a higher risk for cervical cancer, and they should be screened like the average risk patients. So, patients who've had hysterectomies. Patients who have had cervical intraepithelial neoplasia, CIN, they should get surveillance even after a hysterectomy. But if someone's had a hysterectomy, they have no history of cervical cancer, no history of CIN, then it depends on the type of hysterectomy. If they've had a total hysterectomy, which means their cervix was removed, there's no need for screening. But if they've had a subtotal hysterectomy, which means that their cervix is intact, and like I said, they have no history of CIN, they pretty much have the same risk as everybody else. So you just follow the screening guidelines. Now, a symptomatic patient, that's any age, including less than 21, who have signs and symptoms, you need to do a diagnostic evaluation. We're not doing screening, right? That's regardless of prior screening history. And that's going to be a diagnostic pap smear and evaluation for cervical biopsy. And we're going to be looking for abnormalities on visualization or palpation of the cervix, abnormal or postmenopausal bleeding, abnormal discharge, pelvic pain, or changes in bowel or bladder function. So like I said, in general, if you're over 65, you stop. But like I said, any age symptomatic patient, you want to do a diagnostic eval. Less than 21, over 65, you want that diagnostic pap test. You want to evaluate for a cervical biopsy. Also, people who got the HPV vaccine, they should still be screened. It doesn't matter. So how do we do it? I know most of us have probably had experience, but we're going to go through it. So the sample is obtained during a speculum exam. Most often, if you're doing liquid cytology, you can use the same specimen for both cytology and HPV, and that's what most of us have experienced. So the cells, we're going to get them from the ectocervix and the endocervix because we want to evaluate the transformation zone, the squamocolumnar junction, because that's where cancer happens. So based on the research, the spatula and the separate endocervical brush is going to provide way more endocervical cells than just the spatula, and it's slightly better for detecting any grade of CIN than that little broom that we use. So if you have a choice in your practice, go with the spatula and the pipe cleaner brush. So how we collect the sample. Using the spatula, we're going to circumferentially scrape the ectocervix. And it's of note that doing the spatula before you sample the endocervix is going to minimize bleeding. Through the collection process, it's going to be better for your patient. Now, using the brush, you want to insert the brush into the endocervix so that the bristles that are closest to you are at the level of the external cervical os. Like you want to get all the way in there. You're going to rotate that brush like 180 degrees to get that sample. If you're just using that little broom, then you want to insert the central bristles into the endocervix with the outer bristles having contact with the ectocervix. It's the key. And you're going to rotate that broom in the same direction about 5 times. Now, like I said, if we're using liquid-based cytology, then you are going to place the spatula and the brush or the broom in the solution and vigorously swirl or rotate it 10 times. That's the procedure. Fun fact, because I was curious, when that liquid is processed by the cytology lab, those loose cells are trapped onto a filter, and then they're going to be plated onto a monolayer on the glass slide. I think that's super cool. Maybe that's just me. Now, interpretation of cytologic smears are always subject to variability by observer. So we actually have, the scientific community has been coming up with automated slide interpretation systems that perform initial reviews of the cytology slides and kind of identify subgroups that need further evaluation by pathology. This is up and coming technology that's very cool, but rest assured, in the United States, for quality assurance, regulations require that labs rescreen 10% of randomly selected cytology smears that were originally interpreted as negative to make sure that nothing's slipping through the cracks. HPV testing, it is going to identify the high-risk oncogenic HPV subtypes that are associated with cancer, and generally the different subtypes by the different tests vary, but at least every test is going to test the 13 most common. And then you can get the reflex genotyping, or you can order genotyping by itself. I don't know why you would, but you can. That's going to refer to just testing individual types. Like you're trying to know if it's 16 or 18. Sometimes tests will add on 45 as part of that. Additional testing you can do, you can actually check for gonorrhea, chlamydia, trichomonas. There's using the liquid sample, you're able to test for everything at once. And there's no evidence that the order in which you obtain samples is going to affect your cytology results. Now, when you're doing a pap smear, if you see any lesion that's raised, friable, or has the appearance of condyloma, then that should be biopsied regardless of the prior cytology and regardless of other risk factors. If you see it, take a sample. The only thing that you're not going to biopsy is going to be that Nabothean cysts, and you want to have that confirmed by someone who has expert experience in identifying those. Now, it's not always easy to see the cervix. How we can make it easier for ourselves? You can use a longer speculum to reach the vaginal apex, and you can actually press the speculum along the posterior vaginal wall until the apex is reached and then open the speculum slowly, and that can kind of help out. You can also do a bimanual exam to palpate the cervix and identify where it is. And then, you want to optimize patient position. You want to ensure that their legs are sufficiently spread out. They may need to move closer to the edge of the bed. You want to even elevate the sacrum by putting like some folded up sheets or towels to bring up the patient's hips. Also, strangely enough, you want to confirm they have a cervix, because some people have undergone a total hysterectomy and they don't actually realize that they have. They think they still have their cervix. So you always want to confirm surgical history before you do any exams. Now, there's some old wives' tales in medicine, like menses or GU bleeding could influence it. Actually, really, we'd rather you get the test than defer it unless you can't clean the blood off the cervix. Like if it's just crazy amounts of blood, you might want to check that out before you get your cervical exam. And then for liquid testing, because of how it's filtered out, timing in the menstrual cycle doesn't actually have an effect on the results. Also, the interval between pap tests, it can be as brief as 15 to 30 days, and it doesn't actually affect the sensitivity of the test. Now, certain contaminants like lubricant or discharge, semen, spermicide, intravaginal medications, we've all heard like, oh, you can't use gel lubricant. Really, if it's like large amounts that are present, then you can gently remove it with a cotton swab. Removing small amounts of discharge is not really necessary, but really you want to just check with your cytology lab and see which lubricants are approved and then use those. Simple. So you got your pap smear and you get the printout of the results. But like, what does that even mean? Well, luckily, we have the Bethesda terminology, which is a way of making the results uniform and understandable. So, NILM, that means negative for intraepithelial malignancy. You've had an adequate sample and there's no epithelial abnormalities. ASUS, that's your atypical squamous cells of undetermined significance. So those cells are displaying abnormalities that are way more than a simple reactive changes, but it's not displaying squamous intraepithelial lesions. In some cases, those lesions are associated with CIN, and that's why we make special note of it. ASCH, that's our atypical squamous cells, and that cannot exclude high-grade squamous intraepithelial lesion. It's a mouthful. Those cells are likely a mixture of true high-grade squamous intraepithelial lesions and other findings that mimic it. LSIL, it's our low-grade squamous intraepithelial lesion. Those are lesions that are associated with HPV infection, and they tend to be associated with a transient change and most likely can regress over time. HSIL is our high-grade squamous intraepithelial lesions. Those are associated with the high-risk types of HPV, and they have a high risk of progression to CIN or cancer. And then we have our squamous cell carcinoma, which is cancer. So now what? Well, In 2019, the ASCCP, the American Society for Colposcopy and Cervical Pathology, came up with these awesome guidelines to help you evaluate and manage the results. They're based on the fact that screening has mainly shifted to HPV testing, and that HPV testing is more sensitive for predicting cervical precancers. So if you think about it, cytology is great at looking at the current risk of CIN, but HPV is great at predicting both the current and future risk of CIN. So basically what they do is they have a patient risk assessment, and it's the risk of developing CIN3, and it's determined by their current HPV and cytology results, as well as past screening and clinical history. They've got these great tables online. There's this app. It's really awesome. And they basically figured out that the same current screening results can lead to different management recommendation based on past testing results when it comes to like between different patients. So once you've calculated it, you've got this beautiful algorithm. So you basically want to figure out, is there immediate risk of CIN greater than 4%? If yes, what is their risk? And follow the intervention. So you have a patient greater than 60%, you want to do expedited treatment. And it's usually going to be with excision through a loop procedure without really doing a colposcopy first. And that's preferred for any non-pregnant patient over 25 who has that immediate risk over 60. Key thing, immediate cervical ablation should not be done, because then you won't have a specimen for that diagnostic evaluation. And that expedited treatment is preferred to colposcopy because the colposcopy is not going to alter any management. And it's also preferred in patients who are risk to loss of follow-up or have done their childbearing and they're not worried. The exception, it's contraindicated in patients less than 25 and pregnant patients. So patients who are planning future childbearing, or, the ones who are worried about effects on pregnancy outcomes, you can do that excisional procedure after a colposcopy. You kind of want to outweigh the benefits and the worries. The colposcopy biopsy will help that decision making on whether you want to do excision or if an ablation is enough. In all instances, you want thorough decision making between you and the patient to discuss the risks and benefits. So what if the risk is less than 4%? Then you want to look at their 5-year risk. So if their 5-year risk is greater than 0.55%, the return in 1 year, that's HPV-based testing in 1 year. If it's between 0.15 and 0.54, you come back in 3 years for HPV testing. Less than 0.15%, come back in 5 years. Now, some patients and some providers aren't going to be as comfortable with this recommended surveillance interval, and they can opt for more frequent testing. It's really you and the patient talking together. Key thing, pregnant patients. In general, we're going to manage them the same way as non-pregnant patients, but they're not candidates for expedited treatment. Screening will manage the same, but endocervical sampling with the curette and endometrial sampling should not be performed because they have a risk of disturbing the pregnancy. You can get a sample from the endocervical canal with gently using a cyto brush, but really, if the colposcopy is to be performed, it should be performed only if the lesion is present and appears to be high grade, the one you can see. And if CIN2 is not diagnosed or suspected, you can follow up postpartum. We will do postpartum cytology, HPV testing, colposcopy on every patient who has HSIL, but that was diagnosed in pregnancy. But you want to wait at least 4 weeks post-delivery to let the cervix go back to its non-pregnant state. And then patients with a hysterectomy, of course, cervical cancer screening is not generally done for people who've had hysterectomy for a benign disease. But if there was a vaginal cytology or HPV that was done and it was abnormal, if they have LSIL or HPV positive ACIS, then you come back in 1 year. If they have ASCH or HSIL, you want an immediate colposcopy. And you want patients with a history of CIN2 who have undergone a hysterectomy to still get surveillance for up to 25 years because of their increased risk for vaginal intraepithelial neoplasia. So even if they don't have a cervix, because the vagina is at risk, you want to keep screening them. So this magic website, if you go to it and you go to the middle tab, management, and you put in your email and your name, you get free access to the calculator and the algorithm, and it just spits out the risk assessment for your individualized patients. Very convenient. There's also an app. It's like $9.99, and you can get that if you like. Now, if you don't like technology or the internet's down, there is a way to manage average risk patients with an unknown risk estimate. For patients 25 and older at average risk, that means they're not under surveillance for a prior test abnormality. They don't have CIN2 or worse in the past 25 years. They're not immune compromised, and you didn't feel like coming up with a risk estimate. You want to look at the HPV result and the cytology. So if they're HPV 16 or 18 positive and they have NILM or they have unknown cytology, you just go get the colposcopy. Now, if they have NILM and they're HPV positive with an unknown genotype or they're 16-18 negative, then you can do HPV testing with or without cytology in 1 year. If they're HPV unknown or negative, then you can do routine age-based screening. Think about, your patients who are 21 to 29 doing the cytology. That's kind of what they're talking about. They get NILM. If you have ACIS, if you have HPV 16 or 18 positive, you're HPV positive with an unknown genotype, or it's HPV 16-18 negative, but they're still positive, you get the colposcopy. If they're HPV unknown or negative with ACIS, you can do HPV testing with or without cytology in 1 year. LSIL, again, 16-18 positive unknown genotype, or positive with negative 16-18, or even HPV unknown. LSIL, you get the colposcopy. If they're LSIL and HPV negative, you can do HPV testing with or without cytology in 1 year. HSIL. If it's HPV 16 or 18 positive, you want expedited treatment. You're not going to get a colposcopy, just go for it. HPV positive of unknown genotype, 16-18 negative, HPV unknown, HPV negative. If you have HSIL, it's expedited treatment or colposcopy. So really the only reason you wouldn't get the colposcopy with HSIL is if you already know that you're 16 or 18 positive. Now, the special populations, if you're less than 25, you're going to have a high spontaneous regression rate of the HPV and, you, like I said, low risk of cancer. So we're going to treat these patients conservatively. If they have LSIL or ACIS with positive HPV or ACIS with unknown HPV status, you're going to repeat cytology without HPV testing in 1 to 2 years. If they have ACIS with negative HPV, you'll repeat in 3 years. And you can return to routine screening after 2 consecutive negative results. HSIL, ASCH, atypical glandular cells, if they're found at any point, or if you have ACIS or LSIL for 2 years at that follow-up, you want to get the colposcopy. And when the patient reaches 25 years old, you can manage them with the same risk assessment that we talked about before, because that was for patients over 25. So, to summarize, HPV is bad. You want to vaccinate your patients, screen appropriately. You can always check the USPSTF or the ASCCP. And thank you to the ASCCP for your awesome estimator tool, which is going to make our lives a lot easier.